Good evening, good morning, good afternoon rather for some of the people around the world. Welcome again to this series of webinars that we are conducting in collaboration with Narayana Institute of Cardiac Sciences and GE. Some of you may have joined our previous webinar where we had spoken in specific about some of the basics and advances in cardiac imaging. And this is a series of webinars that we plan to conduct, and we are going to be talking on making you comfortable in reporting cardiac imaging. I belong to an institute called as the Narayana Institute of Cardiac Sciences. We are one of the quaternary care centers for cardiac surgeries, and we do extensive amount of cardiac imaging in our practice. And as part of that, I'm going to be sharing some of my expertise, some of my knowledge that I have gained, and hoping that you all should be able to do good quality of cardiac imaging. This is a snapshot of the hospital that I work at in Bangalore in South India. Now, let's just look at what we have been doing and what do we have in mind for all of you who've joined in today. The basic objective for us is that you should be able to report any cardiac or a coronary CT, which includes a congenital heart disease pediatric CT as well. That's our overall aim as part of this webinar series. And to achieve that, what we have done so far is do one webinar which focuses on technology and how to do cardiac CT. Today, we're going to focus on calcium scoring, we're going to focus on anatomy of the coronaries, and then we're going to be focusing on how to build your practice. What we have seen is a lot of people are afraid to invest in technology or have very good technology for doing coronary and cardiac CT, but are unable to get cases sent across to them. Then we will move on to our next few more series, which will talk about how to interpret coronary artery disease. With one by one, we'll talk about stents, we'll talk about coronary artery disease, we'll also talk about bypass grafts, and then we'll talk about extra cardiac anomalies that we need to be looking at in coronary CTs. And finally, we're going to be talking about congenital heart disease, how to get good quality scans, and how to interpret them. The people who have joined us last time and people who have already joined us this time also have asked multiple questions. Unfortunately, we have not managed to get back to you, primarily for the reason that there are some topics which we will be covering, which will be answering most of your questions. And if we are not able to answer those questions specifically, we will dedicate a specific session where we will be taking on questions and then answering those things. So now, just a little quick summary of what we discussed last time. And we said, if you're going to buy a technology to do cardiac or coronary imaging, there are two major factors that one needs to think about. One was temporal resolution. Temporal resolution is determined by the speed of the rotation of the machine that you're going to buy in. The machine which can move really fast will give you better images when it comes to coronary CT. The second point that we spoke about is the coverage that it achieves with every rotation. So 128 slice thickness, which basically means if there is 128 rows of detectors, it will cover about 8 centimeters. If it is 64 row of detectors, then it will cover about 4 centimeters. While if it is 256 slice or 320 slice, they will cover much larger areas of 16 centimeters with every rotation. So wider the coverage, the better the quality of the scanner that you would want to achieve for your coronary CTs. Lower heart rates are always better, and we discussed therapies to use how to keep the heart rate low. But as a simple summary, if you're doing outpatient services, beta blockers are very safe in oral use as well as intravenous usage. Intravenous usage of beta blockers gives you very quick reduction in the heart rates. If your patients can come and wait for a day or so for appointments, then you can also use tablet ivabradine. You can use it at a dose of 5 milligrams and give it the day before the examination, and then that should also give you some good reduction in the heart rate of the patients. Radiation exposure should be as least as possible when you're doing coronary CT. So prospective gating is something which we advocate in all the cases where possible. And remember that technology is advancing really fast. Each vendor has something very good to offer when it comes to coronary CT, and that will also influence in the decision of which CT to take. So this was the summary for what we talked about last time, i.e. you should have a fast rotating system, you should have a system which has a wider coverage of the detectors, and should have the best technology which allows you to reduce radiation dose, but keeping your heart rate, the patient's heart rate low is very, very important. Now let's move on to today's topic, which is on calcium scoring. One thing is very evident in that as part of the atherosclerotic process, a normal aging process, what you are likely to see is that the coronary artery, if this is a cross section of a coronary artery and this is the lumen of the coronary artery, what you will see is over a period of time, disease progresses within the intima or the inner layer of the wall of your coronary arteries. The earliest thing that we are able to detect on simple imaging is calcium deposition. So when you see calcium deposition without any effect on the luminal compromise, you can see patients will not have any symptoms. There will be nothing that can be detected on stress testing or even in normal ECG or echocardiography. So slowly this calcium leads into scar formation, and sometimes you start getting vulnerable plaques which can burst out, and once they burst out they lead to significant coronary artery disease, whereby this is where all the events happen. 70% of events are happening because of these vulnerable plaques bursting out and causing obstructions. And this is quite late in the disease process for us to be actually finding out these patients and detecting these coronary artery diseases. So rather than us trying to treat these patients at this level, the aim of the treatment and prevention regime has to try and pick these patients up much earlier in the disease process so we can modify in the way we can treat them. And this is where calcium score comes in. So what is calcium score? Now, calcium score is a simple CT examination whereby we are not giving any contrast. All we are doing is connecting ECG leads to people's chest, and we basically make them lie down, hold their breath, and the scan is done. The scan takes about 6 to 7 seconds depending on the technology you have. There is no need for any injections. There is no need even to change the clothing of the patient. You can just ask them to get rid of all their metals in their pockets, get them on the scanner, they get the scan done, and straight away they are out of the room. Heart rate may not be a major issue in loss of scanner. If you've got a 16 slice scanner, again, majority of 16 slice scanners are capable of doing this if you have the right software. How does it look? Essentially, if you look on this image, this is what we are looking at. This is a calcium score study whereby there is no need to give beta blockers. There is no need to try and reduce the heart rate in these patients. And all you're looking for are these bright spots of calcium in your coronary arteries without giving any beta blockers or any injections. Now, one thing, calculation of these is it requires a software in most of the places, but there are some free softwares available also for people who want to do this in your scanners and do not have the required software. The score, it's called as an Agatston score. The slice thickness of images varies from 2.5 to 3 millimeters. And the way the score gets calculated is similar to what you would do in any other area. You calculate the density of the calcium. So if the density of the calcium is anywhere between 130 to 199, you get a weighted score of 1. Anything which has a density of more than 400 HU, Hounsfield units, get a weightage score of 4. Now this is multiplied by the area in a millimeter square. So now if you check a coronary calcium score study of yours and you see a plaque which has a weightage density of 400 HU and has an area of coverage of 10, think about it, what would be the calcium score? I'll give you just a few seconds to work it out in your mind. So area is 10 millimeter square and the HU is 400. So the answer to this would be 10 multiplied by weighted score of 4. So the calcium score in this scenario would be 40 Agatston score. Now this is very, very important. Now let's say the heart rate was slightly higher, or the patient did not hold their breath well. The 40 the 40 calcium score may vary a little bit from 20 to 60. But what we are more interested in, if we look at the data which is available, we club together calcium scores on bigger ranges. So you have a clubbing of 1 to 100 score, 100 to 300, and something which is more than 300 as an Agatston score. If your Agatston score increases, what you can see is that the chances of you having a major adverse cardiac event keeps increasing, and it's quite high. So the number of people who had events in this large group is quite high. So 6 to 7 times more likely to have coronary artery disease related cardiac events compared to somebody who has a 0 calcium score. So it is very, very essential. Now if you look at further data which has come up, so if we look back at this article which got published in 2016, very, very useful article which talks about the added advantage of calcium score in terms of risk stratifying patients. So if you look at this is a traditional risk stratification which is based on Framingham risk score, based on classical risk factors that people talk about. You put people as low risk, intermediate risk, or high risk. Now, if a patient with low risk has a 0 calcium score, they remain to be in the low risk category. So for example, when we have a patient and we are thinking in terms of should I be starting them on statins or lipid lowering treatments, you do a calcium score. People, as their score increases more than 400, you need to potentially intensify their treatment. It is very, very important that these patients get treated aggressively to lower down their lipids so that the plaques can get stabilized and they reduce the events that may happen in future. In a different additional experience from the MESA trial, which basically looks at a lot of these things, what they looked at was just the addition of calcium score. Okay, if we just put in that, the risk classification that we would have done in a general standard manner, in 1 out of 4 people, the risk stratification gets changed by just using calcium score. So it is a very, very powerful tool for us to actually start using. Now, why do we insist? Why am I talking so much on calcium score? I'll give you a very realistic example. So we've had people visiting us who come from corporate institutes who have a very, very good health screening package. So they undergo an echocardiogram, they undergo an ECG, they go a treadmill test every 6 months to a year based on their age. And we've had people who have had exactly normal studies in treadmill test, echo, and ECG end up having major cardiac events within 6 months of being told that they are normal. This is scary. This is really scary because a normal treadmill test does not tell you whether you have coronary artery disease or not. All it tells is that you have no significant coronary artery disease. So essentially, if you have a coronary artery disease which is 50% stenosing, your treadmill test may be normal. Your ECG will be normal, your echo will also be normal. And you will be living happily, unaware that you may have significant coronary artery disease underlying this. So we have started doing a lot of calcium score as a screening process because it gives us very good idea of a plaque burden that the patient may have. With a higher score, you're likely to have higher degrees of stenosis. It is very useful, as you saw earlier, in risk stratifying the patients and actually putting them in a lower or higher risk groups in there. It is also very useful in targeting the management by using anti-atherosclerotic therapy in these patients. One thing which we've also noticed is a lot of people do take life a little bit less seriously, in the sense that we've had people who are told that they need to be taking a lot of anti-lipid or statins in their therapy. They do not take it. So we've had patients who we say, hey, your lipid profile is so high, why are you not taking any statins? And they say, no, it's okay, we will be fine, I'm feeling well, doc, I will be going on exercise, I will be reducing my diet, I will be looking after the diet, and I will manage my lipid profile. I don't need to be on statins. 6 months later, their statins, their lipid profile remains abnormal, and you really cannot convince to go on statins. Same patient, you do a calcium score, and the calcium score turns out to be positive, and then you turn around and say, hey, there is evidence for you that you have coronary artery disease, and that basically means you need to look after your lipids much better than what you're doing now. The compliance of that patient in taking statins and managing their lipid profile is much, much higher, just because they know that they already have coronary artery disease. So what's the evidence? Well, if you look at the evidence, if a patient is asymptomatic and they have a calcium score of 0, then there is a 97% chance that you do not have significant coronary artery disease. This is published evidence. You look at our data, we looked at the Indian data. Majority of the data is a published data on some of the Caucasians and some Chinese group, but not much in the South Asian population. In our own population, where we've looked at thousands of data, and we have seen that a 0 calcium score means that 3.4% of patients with a 0 calcium score can still have coronary artery disease in the asymptomatic group. So you have a clearance of about 97% with 0 calcium score will not have coronary artery disease. Even if you have a calcium score of less than 100, the chances of you having significant coronary artery disease is much, much lesser in symptomatic patients. So it actually helps in a significant manner in screening of populations. Do remember that any calcium score is not bad. Okay, so there is a aggregated way. So if you see, this is one chart which is derived from the MESA. Up till your orange line, you're absolutely fine. So if you are a 70-year-old and you have got a calcium score of, let's say, 80, you are okay. That's normal for your age. However, let's put it the other way around. If you're 40 and your calcium score is 2, it is absolutely abnormal. You're not expected to have any calcium at that age. So it is important that we take it in respect to the gender and the age of the patient when we talk about calcium score. So in summary, when it comes to calcium score, it's an easy, non-contrast examination. You don't need to do anything. You don't need a high-end scanner. A 16-slice or a 32-slice scanner can also do this. It is a great motivator for people to get into healthier lifestyle, and it also helps in risk stratification. I'm just going to show you a couple of calcium score examinations that we would have done and how they look, and a couple of questions which have been asked to me in past in terms of at what calcium score do you stop doing coronary CT? Well, the answer used to be, if you had a 64 or a lower end scanner, we used to say any calcium score of more than 1000, we would not go ahead and do coronary CT. But we've started realizing that that was a bit of a fallacious number which was picked out of nowhere, and we did not have any scientific evidence on that. So we've done calcium scores of 4,000s and 5,000s, and there have been no significant coronary artery disease in these patients. So we do something different nowadays. So this is a calcium score study that we would do, and you can see that this is calcium which is coming across here. And you can see this is a circumflex which also has calcium within it, and some minor calcium which is there in the right coronary artery in these patients. So we start looking at the calcium within these coronary arteries. And if you're able to see the lumen through the calcium, a lot of times what happens, it's like a tram track like calcification, where the calcification of the wall is present while there's nothing in the lumen. In those cases, you can go ahead and still do a coronary angiogram study, and you will get good results. But in cases where you see some dense calcification which is extending across the bifurcation, it may not be good to go ahead in these studies. And how do you measure? It's very simple. Different vendors have different softwares. So you will have something like this, where you can select an area and say, hey, this area is corresponding to LAD and RCA, and it will give you a good calcium score in the reports. A different patient, another patient of calcium score, again, nothing much in terms of what you're looking at. You can see here when we start looking at these coronaries. So this is LAD, and you can see this speck of calcium that you're seeing is actually towards the periphery. It will not cause much trouble in us interpreting the study. But when you start seeing this calcium is almost covering the entire lumen, and this will be a trouble for us when we are trying to assess these coronary arteries in an angiogram format. So we do, and again, this is the tram track calcification that I was telling you about. One wall, another wall, in between there is a lumen, and this vessel is something that we will be able to analyze in this patient if we were to go ahead with our coronary CT study. So that is all about calcium score, guys. It is very, very important. It's a very good tool, and I would request all of you to start using it as part of your normal routine practice. The next point comes about is the coronary anatomy. Okay, so you've done a study now, and just as a recap, we would do a scanogram to look at the coverage. We would do a calcium score. Based on the calcium score, we would put a region of interest in the aorta, ascending aorta, descending aorta, depending on how fast your scanner is. We will give contrast bolus, and then once it reaches a good point of enhancement, in some cases 150 Hounsfield units, and in some cases 200 Hounsfield units, totally depending on the machine that you have, we trigger off the scan. The saline flush is following the contrast, so the right ventricle is washed out of neat contrast. Now we've got a study, and we're going to start analyzing the study. So first and foremost is to look at the anatomy of the coronaries. What do we look at? We look at the origin of the coronaries. We look at the course of the coronary arteries. We look and see where do they terminate. And we also look at what is the dominance of coronary arteries. When we talk about dominance, by definition, dominance is described as the vessel which supplies the posterior interventricular septum. So if a branch of the right coronary artery is supplying the posterior interventricular septum, it becomes a right dominant system. If it is the left coronary artery which is supplying the posterior interventricular system, then it becomes a left dominant system. Many a times you also have codominance, where branches from both sides are supplying the posterior interventricular septum. Most commonly there will be a right dominance in around 60 to 65% of cases. 20 to 30% will be left dominant, and there will be about 5 to 10 as a co-dominant supply of coronary arteries. When we talk about origin of coronary arteries, there are a few anatomical landmarks that one needs to understand. So in a normal patient, you can see that that level is the annular plane. That is the level where the aortic valve annulus is, and just above that is the sinus of Valsalva. And the narrowing between the sinus of Valsalva and the normal aorta is called as the sinotubular junction. Coronary arteries arise at the level of the sinus of Valsalva. They do not arise below it, or they do not arise above it in a normal scenario. Okay, and if we take a cross-sectional cut across the sinus of Valsalva, you get a nice view of the tricuspid valve of the aorta, which has 3 cusps, 1, 2, and 3 cusps. This is the atria, this is the other atria, and this is the interatrial septum. The common question that I like to ask a lot of my colleagues and my students is, which of these is the right coronary cusp, which of this is the left coronary cusp, and which of this is a non-coronary cusp? The easiest way of recognizing is the cusp which is closest to the interatrial septum is the non-coronary cusp. The cusp which is anteriorly located is the right coronary cusp, and the one which is left behind is the left coronary cusp. So you have 3 cusps. So ideally, left main stem arises from the left coronary cusp, gives rise to the LAD and then LCX. The right coronary artery arises from the right coronary cusps and then gives off multiple branches. That is the normal anatomy, that is the normal origin, and we will talk about the course of the coronary arteries in a second. You may have anomalies which are relating to the origin, whereby they may be taking off higher than the sinotubular junction, which is then called off as a high takeoff. Clinically, they may not be causing any significant difference to the patient. However, if any procedure is being planned, it is useful for the cardiologist to know that there is a high takeoff of the coronary arteries, so he can modify his procedure accordingly. You may sometimes have an absence of the left main coronary artery, whereby the LAD and the LCX may be directly arising from the aortic sinuses. Again, this is something the cardiologist needs to be aware of. So when they are cannulating these vessels, they know that they have to cannulate them separately to achieve the desired results. You may have anomalous origin of the coronaries from the opposite cusps, or they may not be arising from the aorta itself, and they may be arising from the pulmonary artery. If the left coronary artery is arising from the pulmonary artery, we call it as an Al kappa. If the right is arising from the pulmonary artery, we call it as an R kappa in this. So if you just look at some of the examples, here are 2 examples where you can see that the left main stem is arising above the sinotubular junction in this patient and then divides into 2 branches. In a similar fashion, you can see that the right coronary artery in this case is arising higher up, and so is the left coronary artery just arising above or at the level of the sinotubular junction. So it's important to mention these in your reports. Another 2 different cases where you can clearly see that the left main coronary artery is absent, and you're looking at the LAD and the circumflex directly arising from the left coronary sinus. Something similar in here also. It may also happen that the LAD arises from here while the LCX arises from a different coronary cusp. This is something very, very important. One common cause of sudden cardiac death in young patients is an anomalous coronary anatomy. So if you see in a normal practice, as I said, this is the right coronary cusp, this is the non-coronary, and this is the left coronary cusp. You will have the right coronary artery coming from here, and you'll have the left main coronary artery coming from there. You can have various permutations and combinations of abnormal origin. So for example, the left main stem is arising from the right coronary cusp as a common origin, and then the vessel passes in between the pulmonary artery and the aorta and then divides. On the other hand, in this case, it arises in the same fashion but does not travel in between these 2 vessels, but decides to travel anterior to the pulmonary artery. In a different morphology, you could have it traveling around the aorta posteriorly, or it may go through the pulmonary valve across there. Similarly, you may have a circumflex which is arising from the right coronary cusp, while the LAD may be arising in the normal location. What is important in all of these cases is to clearly ascertain the origin and the course. a vessel, a major vessel, especially an LAD or an RCA, and for that matter even the LMCA, crossing between the pulmonary artery and the aortic artery is called as an interarterial course or a malignant course. In these cases, what tends to happen is at the time of acute stress, the pulmonary artery dilates, the aorta dilates to provide more blood supply to the organs. The coronary artery in between gets squashed, leading to syncope, leading to sudden cardiac death, relating to ischemia and relating to arrhythmia in these patients. So it's very important to try and recognize that and actually point it out within urgency in this case. So let's just show you some examples of this. So you can see that this is the origin of the left main stem, and this is the right coronary artery which is arising from the left coronary cusp and then has an interarterial course between the aorta and the pulmonary artery. A different patient, you can see the left main stem, and again the RCA is arising in this manner. You can see there is this long course of the right coronary artery between the aorta and pulmonary artery where it is squeezed and then it opens up normally. Whenever you see this entity, it is important to look at 2 or 3 major factors. One is to look at the origin of the RCA. Is this normal rounded origin or is it a slit-like origin? Slit-like origin is a poor prognosis. Second is to look and see if there is any intramural course. So when you start seeing a soft tissue kind of wall around the proximal aspect of the vessel, very close to the aortic wall, then it is suggestive of an intramural course of the RCA within the wall of the aorta itself. That again is an indication for surgical correction in these patients because they get squeezed much more than any other vessels in there. So you can see another different view where the vessel is being compressed between the aorta and the pulmonary artery, and in a case of stress you can see that these both vessels really dilating and then squeezing the coronary artery in between in this. Few other things that one has to look for, and there is not much evidence in terms of the importance of these things. The 2 things that we often see is something called as an intramyocardial bridging, intramyocardial course of the LAD. Normal epicardial coronary arteries should have fat around them always, but LAD often dips into the myocardium, has an intramyocardial course, and then it comes back out of the myocardial course to lie in the epicardial space. It is important to actually mention this. In some cases, what happens is during systole, this vessel gets really squeezed, causing ischemia distally, and patients may be symptomatic, although in diastole, the vessels are absolutely normal. So myocardial bridging is an important parameter to describe. However, if we do 100 patients in our practice, at least 40 to 50 people have myocardial bridging of different degrees. Which of these are significant is often a clinical decision, and it's not a purely radiological decision for us to make. So it's important to talk about how long the segment is and if there is actually narrowing that you can see, and then it needs to be correlated with the clinical picture to take decisions. Right coronary artery often has this course whereby it goes through the atrial wall. So it's an intra-atrial course where you can see slight extension of the atria on either side of the vessel, often does not cause any compression, does not have much clinical relevance unless and until we are looking at trying and doing a bypass grafting, and it will be very difficult to graft the vessel at that point in time, and we'll have to graft it distally or proximal to the area of an intra-atrial course. So that's important to mention. But if there is no bypass plan, it will not make any clinical difference in these patients. There's a lot of talk about also talking on the dual LAD classifications. Many people mention a lot about this. We do report it, but we don't give undue importance to this. purely because we describe the anatomy, and if there is no significant coronary artery disease in these group of patients, then it may not have too much of a clinical importance. But it is useful to talk about this, whereby this is the interventricular septum. This is the region which is supplied by the LAD. What you sometimes see is the LAD is defined as a vessel which is actually sitting in the anterior interventricular groove. You get a septal-like vessel which supplies this part of the septum but stops there, which would have been a normal LAD course, and then there's another vessel which comes and supplies the other part of that. So this is a type of LAD where you have a dual LAD, where there is a short LAD supplying some part of the interventricular septum and the anterior segments, and then there is a longer LAD which supplies the rest of the vessel. So if we look at the origin course, then we need to look at the termination. Normally they will go and terminate into the myocardium, but sometimes they will open into other structures. They may open into the heart itself, into the right atrium or the right ventricle, whereby they are called as a coronary cameral fistula. Sometimes you may just see fistulous communication with the pulmonary artery. They are often small and may not have much clinical significance, but that is something which one has to report and mention in these vessels. So let's quickly look at some of the cases that I have planned for you. So we are purely looking at the anatomy, and I'm going to talk to you in terms of how we analyze these cases. So in the next series, we're going to bring in coronary artery diseases, and we're going to show you how to use a software application to analyze these to a very good detail, because that is important. Today, for the practical purposes, we will be sticking to simple axial, coronal and sagittal sections, which can be done in any software which we are looking at. So when we look at this as an axial image, this is a patient who's come in for a coronary artery scanning. One thing I tend to do when I start analyzing in my patients is, first and foremost, I would put this into a maximum intensity projection image on an axial plane, just to understand the anatomy of the coronary arteries. So for your initiation, this is the aortic annular level, this is the sinus of Valsalva, and this is the sinotubular junction where you can see the narrowing of the aorta. This is the right coronary cusp, and this is the right coronary artery arising from it. Often the first branch which comes out of the right coronary artery is the sinus nodal branch, and it goes and supplies the SA node across here. Then you start seeing that the right coronary artery gives rise to acute marginal branches. Some of these branches go and supply the conus of the right ventricle. So the conal branches and the acute marginal branches that we are looking at. In terms of describing the right coronary artery, you can divide them into proximal, mid and distal segment, and the division is based on the branching pattern. Before the acute marginal, proximal, first to the second, mid, distal to the second acute marginal branch, then you call it as a distal RCA. So you can see this is the RCA, and this is giving rise to this particular vessel which is supplying the posterior interventricular septum, that is called as the posterior descending artery, or PDA, making it a right dominant system. Also in this case, right coronary artery gives rise to this another branch which crosses the crux of the heart. Crux of the heart is this part posteriorly where all the four chambers meet, and the vessel which crosses across it is called as the posterolateral ventricular branch, where it goes and supplies the lateral aspect of the myocardium. On the other hand, when we look at the left main stem, so this is the left main coronary artery, it is dividing into two branches. One is the LAD and the other one is the circumflex. Sometimes it trifurcates and gives rise to a small branch which comes across here, called as the ramus intermedius branch. So when we look at the circumflex, circumflex gives off branches. Sometimes it may give a branch to the SA node itself. Otherwise, it is giving rise to obtuse marginal branches, that is OM1, and then again it goes further down along the interventricular groove and often stops there, or again supplies the lateral wall by giving other branches in the obtuse marginal OM2 and OM3. The next thing we look for is the LAD. LAD tends to give rise to two types of branches. The ones which go towards the myocardium laterally are called as the diagonal branches, while the other ones which go medially or inferiorly are called as the septal branch. So you can see this is a septal branch, this is another septal branch, and this is a diagonal branch. This is D1, or the first diagonal, and you can see this is the LAD, which is continuing down further, and then it gives rise to some more branches in there. And what you can see in this LAD is that it's always remaining on the surface of the heart, does not dip into the myocardium, and that is in keeping with a normal LAD that we are looking at. What you also see in this case is that there is significant hypertrophy in the LV, which is in keeping with hypertrophic cardiomyopathy, but we will be talking about that in our next set of series. So let's start looking at some. This is a normal coronary anatomy. So we're going to look at some of the anomalies that one may see. So again, we go back, we put it into a MIP mode, and you can start looking at this coronary vasculature. And you can see that, okay, this is the left main stem, looks okay, but the RCA is actually rising from the left coronary artery. You can look it up on different planar images, and you will see, again, this is an interarterial origin, an interarterial course of the right coronary artery before it starts taking its normal position in there. And it is this malignant course which can be very tricky, and one has to look at these vessels and tell what is the origin, what is the course. So remember, I had spoken about, is this a slit-like opening or is this a normal opening? You can zoom in and see that a normal opening of the left main stem is nice and wide, while this is a slit-like opening across there. There's not much of soft tissue thickening around this vessel across here, so it is not an intramyocardial course in this vessel, but it has a slit-like opening of the right coronary artery arising from the left coronary cusp with an interarterial course. Let's look at a different case, and same thing again in a MIP mode. I'm just going to make it run through for you guys to start seeing this and trying to recognize and see if there is any coronary anomalies that one can pick up in this patient. So remember, always I tend to start off with RCA, and you can see there is one branch which is coming across here. The first branch is often an SA nodal branch, and you realize that, hey, this is not going to the SA node, but it seems to be cutting across the aorta and then goes and sits in the left AV groove, in keeping with a anomalous origin of the left circumflex artery from the right coronary artery, with a circumaortic course whereby it just goes around the aorta but does not have any interarterial course. So it's not a malignant anatomy, it's a non-malignant anatomy in this patient in there. And you can see just distal to this is another smaller branch, which is the SA nodal branch, which goes and supplies the interatrial septal region for that. So this is anomalous left circumflex from the right coronary artery. Another case which is useful for you guys to get acquainted to is something like this. You can see a coronary artery straight away which is coming off from the anterior to the pulmonary artery, which is not usual. That's not a location that one would see a coronary artery. And you can see very nicely that this is a right dominant supply. The PDA is supplying from the right coronary artery. And then when we go down here, you can see that the RCA is just a single vessel, but just there is another vessel which comes off from the right coronary cusp, then goes anterior to the pulmonary artery, and it follows and sits in the interventricular groove and gives rise to branches in keeping with an LAD, which has got an anomalous origin from the right coronary cusp, but does not have an atrial course in there. And you can see this is what I was telling you about. This is very mild myocardial bridging that we can see here. I'll just zoom it in for you guys to get used to seeing this. Usually you would want a coronary artery should have fat and fat on either side. You can see this does not have fat. This is within the myocardium, and after some time it just moves out and sits normally in the epicardial location. So this is intramyocardial or myocardial course of the coronary artery in this patient. One very interesting case that we've seen, this is quite an elderly patient, and one would be surprised. You can see there's a lot of atherosclerotic changes in the aorta. And now when you start seeing the coronary anatomy, what you will see is that there is this funny vessel which is coming across here, okay, and next to it you can see that the RCA arises, and there's a lot of coronary artery disease. For this session we're going to ignore that, and you can see it's a right dominant system with the PDA being supplied by the right coronary artery. And you look for the left main stem and you see, hey, there's no other coronary arising from the aorta but this one. So this is a left main stem which arises from the right cusp, has an interarterial course, then it comes along in the septum with a intramyocardial course, and then divides into circumflex and then the LAD in this patient. So again, this is termed as a malignant course, but you can see there's no slit-like opening. There is no compression between the vessels, at least at rest. So this is a patient who is in his 60s, and it seems to be okay with him and has not caused him any trouble so far. Last couple of cases that we talk about. This is something very interesting and not that common that one may see, but very easily missed sometimes. This is a young child, and what we are looking at in this case, there is a anomalous pulmonary venous connection that we are looking at, whereby you can see that the pulmonary veins are actually draining into the SVC side of the system. But more importantly, and there is a small PDA also that we can see. We'll be covering this later on, but when we talk about coronary arteries, just look at and see where is the origin of the coronary arteries. So it's quite often missed in saying that, hey, the coronary artery seems to be arising from the aorta there. That's just normal. But you start putting it in your different planes and you start looking at it more interestingly, and what you will see here is that the left pulmonary artery is actually arising from the pulmonary artery. This is a case of Al Kappa, and this is a normal right coronary artery arising from the aorta in there. So this is a case of Al Kappa, which is very, very important that we need to be aware of. Last case in the series of coronary anomalies that we can look at. This is a origin of the coronary arteries. You can see again, this is an important one which I keep telling. The right coronary artery is arising from the left coronary artery, but does not seem to be getting compressed here, and then distally it seems to be doing okay. And you can see here as it comes down, the posterior interventricular septum is supplied by this vessel, making it a right dominant system. Now when we go further, you can start seeing there are lots of collaterals across here, and you can see some of these are coronary collaterals which are actually terminating into the pulmonary artery here. So this is a form of a coronary fistula, coronary to PA fistula, whereby we can look at the amount of blood which is getting transfused across this, but often we do not do anything about this unless the shunting is quite significant. When the coronary starts opening into the chambers of the heart, which is what we call as a coronary cameral fistula, they are very significant, and we often have to close those by simple interventions as well. So termination of coronary arteries is important, the origin of coronary arteries is important, and the course of coronary arteries is important when we are talking about this. Final part of the webinar today is talking about how to build up your cardiac practice. Now, I understand we are different people logging in from different parts of the world, where different geographies mean different challenges for us. And some people may not be getting enough referrals, while some people may be getting referrals, but they may not be appropriate in there. We were in that situation where we struggled to get appropriate referrals from our cardiology and our general medicine and general practitioners for coronary CT. And one of the major reasons why that happened was they were not happy with our reporting accuracy, or they were not happy with our reporting patterns. We had long reporting patterns. We had 4 or 5 pages of reports giving all the details which the cardiologists were really not interested in or did not understand it. So first and foremost thing that one has to develop as part of developing a practice is your reporting has to be accurate, and you should have a simple reporting format very similar to what a cardiologist would report. Second thing, costing. Coronary CT should be placed at a very competitive pricing, similar to what a catheter angiography is, because the expenses involved are purely related to contrast and, of course, the investment that one would have made in the machine. But if you have more cases, there is quite likely that you would be recovering better costs in there. If you look at calcium scoring, we have a very, very, very low pricing for calcium scoring. It's just like a screening tool that we use. We want people to start using it. It's as cheap as 2 chest radiographs in our practice, whereby we do calcium score at that cost, because we want to screen people. We want to make people aware of their coronary artery disease so they can treat themselves better. Communication is key. Communication to the patient, communication to your cardiologist is very important, because as soon as you see something important, or if you see something which you do not understand or you cannot accurately quantify, please call them and tell them, hey, I'm not sure what's happening. Can you please help out? And they will develop confidence in you and start sending you cases. You would be very amazed to know that cardiology colleagues and general practitioners may not know much about the advantages of CT. You would imagine they would, but they probably are not aware of it. And whenever I've spoken with some of the cardiologists, they've said, oh, we didn't know that you guys could do that in CT. And they are very happy to refer when they know that we can do this at a lower contrast, at a lower radiation dose, at a cheaper cost, and very little morbidity to the patient as compared to catheter angiography. When we talk about indications, okay, when you're talking to them about indications, you can turn around and say the way major patients of ours are stable patients with chest pain, but they are stable, and we have a very, very, very high negative predictive value. If we say it's normal, it is normal, and they don't really need to worry about it. Our sensitivity can be a little low. Specificity is in the 80s, which basically means if I say 60% stenosis, it may turn out to be 50% or it may turn out to be 70%. Okay? But if I say it's normal, it is normal. There is no talk about it. A non-calcified plaque in isolation is also an independent predictor for any major adverse events. So these are things which we need to be telling our referral clinicians, and that will give them enough confidence to start sending patients. Another thing which we have started doing a lot now is actually doing acute chest pain patients, but not very typical of coronary artery disease, and you're not sure whether to take them into catheter angiography, and it's an N-STEMI pattern whereby the ST elevation is not there on ECG. They could have a pulmonary embolism. They could have an aortic dissection. There is very good literature which supports that if you use CT early in the diagnostic pathway, the number of days that the patient stays in the hospital and the costing comes down significantly. So it is very, very useful in these patients to be doing this study. One big group which we have been scanning for a few years are patients who are come for, let's say, a cholecystectomy, and they want a cardiac clearance. In those patients who are asymptomatic, but they just want a cardiac clearance for anesthesia for other procedures, CT is excellent. Now we've even started using CT in patients who are undergoing aortic valve or mitral valve surgeries in younger age, where you want to be sure that they do not have coronary artery disease, and it is very helpful in these. Patients with bypass, CT is excellent. Very, very good at both assessing the grafts and the native coronary arteries without having to do any interventional procedure in these patients. Stents, if you're starting off, please stick to stents which are bigger than 3 millimeters, and if they are in the proximal segments. One big group of patients who we scan are asymptomatic patients, but they have high risk, or they are really worried about them. Okay, or who are good friends of ours, because we've had recently few of our colleagues who have no symptoms whatsoever, and they said, hey, you've got a new scanner, I'm worried, can you scan me? And we scan them and we find surprises. The patients who have no symptoms have 80 to 90% stenosis, and it really changes their lifestyle. You can treat them better. Cardiologists, we've had cardiologists who would not send their patients for CT angiography, but would rather do catheter angiography to them. But when it comes to their own coronary arteries, they come for a CT. So people are aware that CT is very good, especially in low risk patients to intermediate risk patients. High risk patients, please send them to catheter angiography. It does not require CT. Those patients would be better off with catheter angiography in that. So finally, the message to give to your cardiologist when you're talking about sending cases is, number one, it is very, very accurate. It's non-invasive and it's cheap. Give them the assurance that we are going to be sending these patients back to you for their treatment. They will need catheter angiography when they have significant coronary artery disease. So in that manner, you're saving the cardiologist from unnecessary radiation that he gets exposed to when he's doing a diagnostic catheter angiography procedure. Double rule outs, triple rule outs, where you rule out pulmonary embolism and aortic dissection at the same time, is very, very useful. Calcium score is a great screening tool and one should start using it. So as a take-home message from today, calcium score has to be something which I would love all of you guys to go back to work on Monday and start doing it if you're already not doing it. First and foremost, look at the anatomy. CT is very, very good at anatomy. Catheter angiography can pick up the origin, but really struggles to understand the course of the coronary arteries, and in many cases it does not even pick up origin if it is anomalous in nature. So to build a practice, communicate, educate your practitioners, and it is important that you are putting the right test and you're giving an accurate reporting in there. Thank you very much for joining in. I would like to thank my fellows, Dr. Onkar, Dr. Richa and Dr. Shamim for helping me in preparing this presentation and sharing our data with you guys. I've got some questions in the last 2 minutes. I will try and answer these questions and we can take it up. Sir, do we need to have some fixed KVP settings in calcium score? The answer is there is a lot of talk about having different KVPs. Let's say you change from 120 to 140 KVP. The density of your calcium changes, i.e. your calcium score varies. So in classical pattern, we do not change our KVP settings. We keep it at 120 irrespective of the age and irrespective of the build of the patient, to try and get as close to the provided literature which has been published. So we try to stick to 120 kV. Sir, do calcium score indicate degree of stenosis and do they correlate? Very nice question. We have looked at, I would like to thank Richa for this specifically, because we were looking at our data yesterday night to present it today. So we looked at 11,000 patients of ours, and we tried to correlate the severity of calcium score versus the coronary artery disease. It does not correlate in a very highly accurate manner. So put it this way, With increasing calcium score, the degree of stenosis increases. Okay, there is a directly proportional relationship. However, if your calcium score is 4000, does not mean that you will have 80% stenosis. It at an individual level, it does not work out. So higher this calcium score, the higher the likelihood of significant stenosis, but it does not coordinate very well for an individual patients. Is the imaging protocol for follow-up cases of stents and grafts same as the routine protocol? No, they are not. For the grafts, you want to cover the entire chest. You want to be covering the origin of the internal mammary arteries, and the scan breath hold time increases. When it comes to stent, you want to be doing high definition reconstructions. Otherwise, and in stents, we do not do calcium scores when we are assessing the stent vessels, because they already are stents in there, and the coronary calcium from the stents are very, very difficult to differentiate one from the other. Where to place trigger bolus scan and why? The positioning of the trigger bolus will vary depending on how fast your scanner is. If your scanner is really fast, then you can actually place the trigger even in the descending thoracic aorta. Okay, if your scanner is really slow, you may have to place it much earlier. Some places may even place it in the left atrium or the left ventricle because the scanner is slow. Traditionally, ascending aorta is a good balance between the slow and the fast scanners, and you will get enough of reports in there. So, last questions. Okay. Is it advisable to do a coronary angiogram if the calcium score is very high? The answer to that question is it depends on the technology that you have. If there is a patient of high risk and they've got a calcium score of 2000, one would argue that, hey, let's do a CT, and if you show no significant coronary artery disease, then you're avoiding them a catheter angiography. While the other would say that with a calcium score of 2000, the likelihood of having significant disease is much high. So you're better off to actually do these patients, send them to catheter angiography so they have one test which is accurate, and they can have an intervention if it is required at the same time. What we have realized is that calcium score number is not the right point to look at, is the distribution of the calcium. If you're seeing chunky calciums at bifurcations in the left main or in the LAD, avoid it. Even if the calcium score is something like 700 or 600, you're better off in doing studies when the calcium score is higher but along the periphery of the vessels. Then you will get very accurate reporting. So thank you very much for joining in this webinar. I hope you guys learned a few things. We will continue with this series, and these eventually will be made available online for all of you to see and follow up. And next session, we're going to be talking about how to assess coronary artery stenosis. We'll have some software packages to go through these vessels, and we will look at different grades of stenosis, how to grade them, if you have software, if you don't have software, what is the best way of doing it, and how to be accurate at that. Thank you very much for logging in. Have a great weekend.